back. Now recognize the new vice chair of the Health Subcommittee,
Thanks.
Ms. Harshbarger of Tennessee.
Thank you, Chairman Griffith. I appreciate that, and it's an honor to be the vice chair. You know, it's the first reauthorization of a MOFU, and it's important that we get it right. And we've made a lot of progress in the first 5 years of this, but I don't think we've realized the full potential of what Congress set out to achieve on behalf of consumers with this. And so we need to work through that to improve the regulatory certainty and minimize regulatory burdens where possible. And I've got a lot more questions for you. But anyway, we'll start with Dr. Chin. I represent a very rural area in East Tennessee, and I also co-chair the Congressional Bipartisan Rural Health Caucus. And we continue to hear that patients in rural areas have a much harder time accessing quality health care services, which is often due to a lack of providers in the immediate area, and we need to ensure that taxpayer resources are reaching the communities that need it most. And the term disadvantage is used throughout Title VII and Title VIII of the Public Health Service Act. And my question is, how does the Secretary define such a term?
The definition that we use in our programs often is directed by statute. And if there's a particular program that you're interested in, we can follow up with you afterwards with the specifics.
Okay. Do what? Oh, okay. Mr. Morris, I joined Representative Emmanuel Cleaver to introduce bipartisan legislation to expand the scope of rural health grants to include mobile integrated health and community paramedic grantees, enabling Americans in rural communities to receive centralized mobile and preventative care through local paramedics. And it's an increasingly popular initiative in healthcare known as community paramedic. Currently, EMS is considered a service provider of transportation. However, EMS has progressed over the years to become a crucial part of a healthcare system. And what are your thoughts on reform of the current EMS system? And does HRSA see the value of community paramedic as a part of the future of EMS and healthcare as a whole?
Thank you for the question. Yeah, the use of community paramedicine, mobile integrated care, has been growing for the last 10 years, and it's another example, I think, of the creativity that rural communities can bring to this. I think what spurred its creation was you had EMTs and paramedics with downtime between calls, and somebody had the idea that they could go do blood pressure checks or home visits, and it extended a somewhat constrained workforce. So I think it's worked well. We funded a number of those programs through the rural health outreach over the years, and I'm sure we're going to continue to fund them because they really do work. I think the larger challenges are how to sustain them. There are some pathways forward where it might work well in a value-based care system, but we're also in a fee-for-service system. So part of the challenge is figuring out the best way to cover those services.
Yeah, we're looking at a lot of different ways to pay for different services. Telemedicine is another. So, you know, they fundamentally believe in the right care at the right place at the right time, and that mentality means that the emergency department isn't always the best place for that patient, and often those patients can be treated in place or via telehealth. Do you see how that's not only good for the patients, but also for really the financial portfolio of the healthcare system as a whole?
Yes, ma'am.
I agree. Dr. Corrigan-Couray. Independent pharmacies are the bedrock of our communities, and can you tell us how Cedar is operationalizing the OTC ACNU pathway in order to expand the role of consumer health products and helping consumers manage their health?
Sure. You're referring to our additional condition of use, which is a PDUFA program.
Yeah.
Yes, there's lots of flexibility in operationalizing. You know, a company will come in and they will establish that the usual sort of drug facts label is not sufficient for selection, and then there'll be another condition of use that will be put on, whether that would be, you know, going to a website, whether you could have something within a pharmacy, you know, some questions, electronic kind of questions, but something that you would have to satisfy that condition of use before you access the product. And we really think that this is going to be key to getting more of those products that we just can't, you know, get that self-selection through the label, and perhaps for chronic diseases. And so we'll be working with companies on how to innovate in this area.
Okay, that's very, very good. As a pharmacist, that makes me feel good. And then there's certain things that should be kept behind the counter, but we'll talk about that later. Thank you. And I yield back.